Welcome to the At a Total Loss podcast, where real-life lost moms talk about stillbirth, baby loss, grief, survival, and all things in between. I'm Catherine, a lost mom to my beautiful son, Brody, who died at full term and was stillborn in January of 2022. I had no idea what to do after his death, and I thought the sadness was going to kill me. So I immediately reached out to other lost moms to try to find somebody who knew how I felt. And it was these conversations that saved me, and I hope that they can do the same for you. We talk about everything. I even interview support people and partners, people who have another perspective on what this life of loss is like. So here we are, you guys. Pull up a chair, maybe grab some tissues, shoot, maybe even a glass of wine, as we hash out what life looks like after the death of your baby and all the things that leave us at a total loss. Me patience.
My patience, yeah. I'm proud and honored to be able to take care of people, to help them, of course.
I've been getting more involved myself after our discovery. So, it was really important to me, and a lot of ladies and mothers and parents reach out to me to ask questions. How do I find out what happened? Because unfortunately, as you know, why you're probably very busy with a lot of us, is because their OBs are like, everything looks perfect. And that's just not enough for them. So I've been passing your name along, just passing out your business card, because I think the most important thing is finding an answer, not even just to close the chapter of what happened, but to release blame on ourselves and then moving forward in pregnancies after that, because a lot of us lost our first and we didn't know what kind of cards we were dealing with. So yeah, it was important for me to have my audience hear you talk, because I do talk about you a lot, because you were a big part of my journey in finding answers. And so I appreciate you hopping on and doing this and kind of getting the word out there about EPV and all that good stuff on a Friday afternoon.
Of course. And I think you really said it so accurately. Virtually no pregnancy loss is the fault of the mother. And that is one of the most uniform things that I experience when I speak to families with losses, especially the mother. In all honesty, right, I have 3 children, but I didn't carry them, so I don't know personally what that's like. But I think for a woman to have life inside of her, she is already triggering to be their mother and to be taking care of them. This is her child, of course. And if she loses that pregnancy and that child dies, she feels very bad, like somehow she failed, right, to do her job as being mom. So I totally understand that. And I think, and I also agree with you, the first step is to understand why it happened, right? You need a really concrete answer, because you can't not only move forward emotionally, but you also can't move forward with any subsequent pregnancies if you don't have an idea of what went wrong. So I agree with all the things you said.
Well, I want to kind of back up just so anybody listening just get some background. How did we come to have this conversation? I mean, everybody knows that I obviously reached out to you last year to get some information on Brody, but how did you get to this place? I know that you've worked with your dad, but take me back to your history and how we got to your focus and helping all of us here.
Sure. Well, it is a journey story, and as most journeys, it's totally by serendipity, without any good planning, and completely by chance.
I love it.
That's usually how things work. So I'm the oldest of 4 boys. My father, the electrical engineer, mathematician. My mother, the English professor. I really thought I was going to be an engineer, but in 10th grade, I had a biology teacher, Miss Ann E. Fullerton, who got me turned on to biology. This was 1969. The world was very chaotic then. You don't know that, but we had Woodstock, we had the Vietnam War, we had lots of chaos, and Annie Fullerton gave me a sense of stability with biology, and it was a very beautiful thing. So I really initially wanted to be just a researcher to study biology, and I realized when I worked at Sloan Kettering, I worked there for a summer when I was, I think, 19, that the PhDs were bossed around by the MDs. The MDs were sort of in charge. So I said, you know what? I don't like when people tell me what to do. So I better get an MD and a PhD. I was lucky enough to end up at University of Chicago, which is a fantastic place. And after my PhD in a very basic science area of biochemistry, red blood cell membrane biochemistry, I went back to the clinics and I did obstetrics and I loved it. I delivered 30 babies in 2 weeks. I had a great time. And I just assumed I would go into obstetrics and gynecology. But they were discouraging. They said, if you really want to be a physician scientist and you take that seriously, that would not be the best choice because, and this is actually relates to our conversation, because we can't really do research and randomize pregnant women to different protocols, right? We'll get to this when we talk about EPV. I think it's still true. There are limitations to what we can do in terms of research to advance things. Ironically, as much as we want to make things better in pregnancy, we can't do what we do with cancer patients, for example. If somebody has pancreatic cancer, their chance of survival is only 5%, sadly. So those patients, we randomize them to new drugs, new procedures, and everybody accepts that. But in obstetrics, we can't do that. So they sort of pushed me away from that. I ended up choosing pathology because I'm visual and it's still science and medicine. Ended up at University of Pennsylvania, which is a great place. But I realized that I don't get along with pathologists, actually. I scare them. I'm way too social for them. And I missed patient care, to be honest with you. And so I just made a basic decision. I said, you know what, I'll finish pathology and do my board certification, but I'm going to go back to OBGYN. And the way I'm going to do that is that the head of obstetrical research at Penn, Jerry Strauss, gave us a lecture, one of the residence lectures. I said, I love what he's doing. So I started working in his lab. I was lucky enough, this is the serendipity, to start working on placenta. And I became fascinated. I knew nothing about the placenta, zero. And I started working on it. I said, wow, this is an amazing organ. It's this total support system for the fetus. It's responsible for implantation, for the early parts of pregnancy, for making all the hormones of pregnancy, for basically sustaining and maintaining the life of that embryo and fetus, period, throughout the pregnancy. And what was interesting is pathologists did not like placentas. They viewed them as sort of the lowest of the low, not really important, because for most pathologists, cancer is the thing that they're most interested in. That's like the cutting edge of pathology. If you get a biopsy during an operation and you tell the surgeons whether it's cancer or not, or what to do, and that's sort of the highest level of pathology, activity at this point. So for me, expressing an interest in looking at the placenta was like saying, I like cleaning bathrooms. That was kind of the way they viewed it, is that, oh, well, okay. Yeah, it's true.
What?
Yeah, because it's just, the first thing you do when you're a pathology resident is you go to the morgue and do fetal and newborn, autopsies, and you look at placentas, and they're basically saying to you, the message is clear. This is not that important, right? You're its first week of pathology residency, and we're going to give you sort of the least important thing to do. But I said, gee, I'd like to stay and clean the bathrooms. I actually find it interesting. So the more I showed an interest in the clinical work of looking at placentas and the clinical cases and speaking with the OBGYNs, the residents and the attendings to understand what was going on, the more placentas were sent to me. So first, all the placentas at University of Pennsylvania, then at Jefferson and other places in Philadelphia. And my reputation started to expand to the point that the chairman of OBGYN at Yale learned about me and said, wow, here's an MD PhD, a physician scientist who's trained as a pathologist but loves OBGYN, is interested in the placenta. I want him here at Yale. So Fred Naftalin, who is like my fairy godfather when it comes to my career, recruited me to Yale. I'm very grateful for that. My wife and 3 daughters were not as thrilled. They love Philadelphia. They were not thrilled about moving to New Haven, but we've been here 32 years now. So, they've adapted, and the girls are long gone. So they're in their own cities right now. So I've been not only happy at Yale, but Yale's been a great experience for me because I am in the OBGYN department, even though I'm trained as a pathologist. So I went back to my roots, my first love, which is taking care of patients, doing research, teaching, but focusing on pregnancy complications, infertility, recurrent pregnancy loss, and sort of the center of the wheel, right? The center
Mm-hmm.
of the axle where all the spokes come out of is the placenta. So
Mm-hmm.
that has really been the focus of my life. And all the things I've discovered, whether it has to do with the placenta and autism, whether measuring the volume of the placenta, whether understanding how, why pregnancy losses occur, all of my quote unquote discoveries or advances are because of my taking care of patients. My patients are really my teachers in the sense that their problem, if I don't understand what's going on, becomes my next thing that I have to work on to solve. And
Mm.
that's what happened with placental volume. I think it was the early 2000s when I had a few cases in a row of stillbirths, and I found that the placentas were extremely small, and they were way too small for the size of the fetus. The fetus might have been a normal size, but their placenta was really small.
Mm-hmm.
And I started asking my colleagues, remember, I'm in the OBGYN department here at Yale. I asked my maternal fetal medicine colleagues, why aren't you looking at the placenta? I mean, obviously that's the entire support system. So why aren't you looking at it? I said, well, Harvey, it's too hard. It's a weird shape. It's like a beanie cap, right? It's this curved thing. And, well, we can measure the distance across from the head, the circumference, the length of a bone. That's easy to do, but a placenta is difficult. So that's where my father came in. He was unfortunately passed away in 2019. He was a mathematician and engineer. And basically, I grew up with him giving me math problems all the time. So I said, Dad, I have a math problem for you. You've given them to me all my life. I have one for you now. If you take a placenta and cut it down the middle, and you take these three particular measurements, the width, the height, and the thickness, can you figure out the equation for me that tells me the volume, the three-dimensional volume of that, spherical cap is what it's called. And he did that. And then, okay, having the equation is step one. Step two is to ask the question and answer it. Does this equation work? Can you take this equation, measure a placenta with a 2D ultrasound, and then does it actually reflect the actual weight and size of the placenta? So in 2010, we published our first paper, which showed, yes, it works very well. There's a very good correlation, almost 90% correlation between the estimated placental volume measurements and the actual weight, which is the same as the volume of the placenta. So that's where it started.
And so do you see patients for this now in person where you are, as well as have us submitting to you consistently?
So my position here at Yale in terms of patients is a consultant.
Okay.
So I don't see patients during their pregnancy. I don't manage labor and delivery. I work, of course, with my colleagues who have pregnant patients, and I'm a consultant all over the world for patients. But most of the patients I deal with are through either physicians asking me to review a case of theirs
Mm-hmm.
or patients themselves finding me. And although COVID, of course, with over 1 million deaths in our country alone, was a horrible thing, and we're still dealing with it. I literally have had 2 or 3 stillbirths just in the last month because of COVID. So this
Mm.
is not something that is going away yet. But one of the positives about COVID has been that because for at least 6 months or longer, we couldn't see patients in our clinics in person,
Mm-hmm.
that I started to do Zoom consultations with patients. And that really has opened up the floodgates. Before that time, a patient would have to come to Yale University to my clinic to see me. And of
Mm.
course, that did happen. But, it's challenging. Of course, if you're in Connecticut or New York or Massachusetts, Pennsylvania maybe. But, some people drove long distances, but it's pretty challenging to do that.
Mm-hmm.
But when you're offered the opportunity, if someone says, I'm going to figure out why you had a loss, explain it to you, especially since no one has done that so far for you, and you and I and your partner can meet by Zoom for as much time as you need to talk about it.
Mhm.
Well, that has been, that has been a need, an unsatisfied need, basically, clearly. There's
Mhm.
so many families that have come to me and asked for my help. As I said, I'm honored to be able to help as many people as I can.
That's basically what happened with us. Brody died unexpectedly at 36 and a half. However, we reviewed with you that they had changed my due date. You noticed that they had changed it by 10 or 11 days, which I fought them on, but they always told me it was not a big deal. But that was only after talking to you. So my point is he was full term and there were no signs. And then when I had an autopsy and a placenta pathology done by wherever the hospital sends it to. That's the thing. You just don't know where it goes or who's even reading it. And then when it came back, my OB said, he's perfect. You'll never know what happened. And it's blatantly right there in front of her what could have been the cause. So that's why I found you. And I think another lost mom was like, you got to call Dr. Kliman. So I was like, this is not good enough for me. And so I sent the slides from the hospital to you, and Kristen was amazing. She helped facilitate getting there. I think they were like overnighted. And then within a few days, you had your report and then you put it in layman's terms, which was great for me to kind of decipher what's happening. But then we met on Zoom for 2 hours. And when I tell you, the relief that I felt in knowing it wasn't that I laid funny or I ate something wrong or something that I did was massive. However, it shifted into another kind of feeling of why didn't my medical team care enough to dig into why this happened? Why was I told it was like being struck by lightning? Why did they tell me he was perfect? Why was I having to find you to get answers as to what happened? Because what you told me is severely, helping in helping me get through this next pregnancy that I'm in. If I didn't have the information that was given to me, I would be blindly going through this and it could potentially happen again. So why do you think there's so much pushback on this kind of topic when we go to our current providers and even future providers?
Oh boy, that is a big question. Um, I think change is difficult, number
Mhm.
one. I think two, there are a lot of components. There are a lot of layers. I'm thinking of Shrek, where he said, "Oh, an onion, layers," right?
Mhm.
There's so many layers to this question. Um, Even the simple, very first layer, if you say to a doctor who's been taking care of patients for a long time, let's say in your current pregnancy, you say, I had a loss because, I lost my son because his placenta was way too small to support him. And therefore, I'm concerned about my current pregnancy. And I really, for my peace of mind, want to have this special, measurement. It's a simple ultrasound measurement. It takes 30 seconds, but it would help me just emotionally. And maybe if we start to see a problem after 30 weeks or 32 weeks or whatever, maybe it could help, determine what to do or when he should be delivered. Let's say you just pose that. One of the responses is, well, I'm a maternal fetal medicine specialist.
Mhm.
I'm an expert. I'm a great doctor. Why are you questioning my ability to take care of you? Right? I'm board certified. I've gone to my fellowship. I take care of hundreds, if not thousands, of patients. I've had no problems. So, it's viewed as a challenge right there. And that's sort of a human response, right? If I were to say something like, I really like your shirt, but would you maybe consider a gray one instead
Mm.
of the green one that you're wearing? Well, what do you mean? I can choose what shirt I'm wearing. Plus, what's wrong with my shirt? Plus, who are you to tell me what to wear?
Exactly.
You know what I mean? So it's like, I think, again, I feel for these people in a way because they are excellent doctors. It's not that they're doing anything wrong. It's just that it was not taught to them in their standard, fellowship program or their, post fellowship training to pay attention to this. And, the real problem, I think, with this is stillbirth is rare. It's
Mm.
less than 1%. On average, it's 0.6%, 6 per thousand. So that means that without even doing anything, over 99% of the time, if they just do their routine care and don't pay attention to this issue at all, it won't even come up, right?
Mm-hmm.
So that's a lot of cases that there are going to be no problems for, right? There won't be stillbirths. So, there's like a cost benefit analysis in terms of for them, like how much effort should I put into a case when I know that what I'm doing is actually going to be just fine for the vast majority, 99% of my patients. So I think for all these reasons, it's an issue, which is why I've never viewed estimated placental volume as a diagnostic test, right? It is part of the screening toolbox. And all I've asked, over the years, and all I've said to people that I've had a discussion is, why don't we just add it into the toolbox? Because right now, there is no test that can predict stillbirth. None. No method. The non-stress test, which is electronic fetal monitoring, is a failure at diagnosing stillbirth. It doesn't work. It is not a screen for stillbirth. There is no actual test for stillbirth. But I have sort of a logical thinking about this, which is that the placenta is the entire support system for the fetus. Let me put it a different way. There is no such thing as a pregnancy with a fetus only. Never. The fetus is 100%, not 99.2, not 99.8, but 100% dependent on its placenta. It is the root system of the tree, right? If you cut the roots off of a tree, the tree will die. If you remove the placenta, the fetus will die. So since the placenta is clearly so critical, no one argues about that. And it has been shown that a small placenta is the number one cause of stillbirth. And there are different ways that people call it. There are different terminology. Some people say placental insufficiency. Really what they're saying is a small placenta, because even a small placenta up until the last minute is extremely efficient in keeping the fetus alive. The typical scenario we see with stillbirth and small placentas is a normal size fetus who might be at the 50th, 70th, or even 80th percentile. Everybody says, wow, this is a perfectly normal size, baby inside of you. Everything is great. And yet, because they didn't look at the placenta, they don't realize there is this terrible mismatch between the size of the fetus at, let's say, the 75th percentile compared to his, we'll make it his for this case, his placenta, which is at the 3rd percentile or the 2nd or the 1st percentile. That's like having a 18-wheeler truck that's being run by a lawnmower engine. Now, maybe the lawnmower engine can keep the truck going up to a certain time, but as the truck gets heavier and as the hill gets steeper that the truck has to go up, the engine will keep running right up until the time it stops. So I actually view that little engine as, well, not only the little engine that could, but very efficient in keeping the truck going. But it's like a rubber band. Eventually you stretch the rubber band to the point where it breaks. So all I've said to people is just add it to your consideration. I'll give you a classic example of a case, which I think is a reasonable case for people to think about. And this is a real case, but I'm going to paraphrase it. A woman comes in at 32 weeks with decreased fetal movement. That is often sort of one of the early markers that there's a mismatch between the size of the fetus and its placenta. So in this case, the doctor happens to be doing EPV on all of her patients, and the doctor does it on this particular patient and finds that the placenta is less than the 1st percentile. While the baby, the fetus inside of the mother, is, I think, the 60th percentile. I don't remember the exact numbers. So that's a big mismatch. And the doctor says, well, we're not going to deliver you right now because all you have is decreased fetal movement. The amniotic fluid is good. Your non-stress test is good. Your biophysical profile is good. In other words, all these other markers are good, but I want to see you in a week. In other words, we're not going to just wait until you're 38 weeks or 39 weeks before I see you again. I'm going to actually see you in 1 week. So the doctor sees the patient in 1 week. And again, the estimated placental volume is the same. The fetal percentile is a little bit down at this point, within the range of it was before. It maybe went from 60 to the 50th percentile. The amniotic fluid is still okay. Everything seems okay. And in fact, the mother is saying at this point that she does feel fetal movement. So that's reassuring. She says, well, I still want to see you in a week. So she sees her in another week. And at this point, the amniotic fluid index, which comes from the urine of the fetus. So the more the fetus can absorb fluid from the placenta, the more it urinates. And that actually makes the amniotic fluid.
Oh, I didn't know that. Okay.
Yeah. So the less, perfusion and the less support of the placenta, the amniotic fluid starts to go down. At this point, the amniotic fluid goes down a little bit, but it's not at the level yet where by itself you could trigger delivery, but it is gone down a little bit. And the estimated fetal weight has now gone down percentile wise. In other words, the fetus is starting to level off with its growth. It's not maintaining the same percentile. It's maybe at the 40th percentile now at this point. Well, a lot of people say, well, as long as the fetus is above the 10th percentile, that's okay. Well, they're missing the point that the percentiles are starting to go down. Well, that to me is ominous a little bit. But luckily, this doctor is persistent. So she says, I want to see you in another week. Now, I forget exactly what week it was. I think it was about 37 and a half weeks finally, where when the patient came in, of course, the estimated placenta volume is still very low, right? The fetal estimated size is now the 25th percentile. So it's almost stopped growing right at this point. And finally, the amniotic fluid index is a level at which it's below the threshold of being normal and healthy. And that is enough of a trigger for this doctor to deliver the patient. And so now we have a healthy baby boy who is, probably, I think, ultimately, I think the 15th or something like percentile, forget exactly the number. The placenta, of course, is very small, as was predicted. And we have a living baby. So it's a great story. The problem from the people that I deal with to quote unquote prove that EPV can prevent stillbirth is they will say to me, well, you don't know for sure if that baby would have died. And so that's the quandary. It's like, my question is, how many babies have to die before we realize that this is actually something that's useful? And maybe the only way to prove it to the people who need this randomized trial approach to things is to actually randomize patients and just collect the data and do nothing, right? Don't save any babies' lives, just collect the data so no one knows what the data is, and retrospectively go back and see, well, see all these babies who died, and we knew that the ratios were really bad. If we had intervened beforehand, we would have been able to save their lives. I mean, maybe is that enough? I asked the question out to the universe. Will that be enough if we do that? And again, how many babies will need to die in studies before people say that measuring the placenta is a reasonable thing to do, given what I said before, that the entire pregnancy, the fetus is 100% dependent on its placenta. So it doesn't seem unreasonable to me, in my personal opinion, to be measuring the placenta. I will say one final thing about this in terms of pushback. And again, it's with deep sympathy that I say this. I work with these people. I'm obviously fond of all my OB colleagues, et cetera. They exist in a very intense litigious environment, right? It doesn't take much for them to be sued, whether they have any responsibility or not for anything. And the vast majority of cases, at least 90% of the time, OBs or MFMs have done nothing wrong, even if there is a stillbirth, right? They're still performing their medical work in what's called the standard of care. They're doing exactly what is expected and assumed to be normal care. So I think that there is a fear by some people, and it's not unreasonable, that if they do something that isn't completely the standard of care and there's a bad outcome, then fingers could be pointed at them saying, well, you didn't do exactly the standard of care. Why are you doing this test? And why are you acting on it when hasn't been proven to be something you should do for every patient, or at least patients that have decreased fetal movement? So I sympathize. So it is a hard problem. I will say that myself and the many women and patients that work in measuretheplacenta.org, an important organization, and also Push for Empowered Pregnancy, we are trying to figure out ways to satisfy the people who want studies and scientific answers and things like that. And we're trying to design studies that will address their concerns so that we can satisfy their need for quote unquote proof that this is worth doing.
Yeah, I think what's interesting about when you start to ask, can you please do this, especially in another pregnancy afterwards, it's like, oh, we don't do that. We just monitor the baby's growth. And I say, well, my baby was measuring perfectly, but he was 7 times bigger than his placenta. And it's like their eyes pop out of their head. They're like, what, how? And they don't know what to do with that information. So here we are, and I'm now a big advocate for us to go in there and say, it's okay to kind of school your doctors a little bit, to hand over even your paper where the instructions and say, I would really appreciate it if you just take a look at this and find somebody who's willing to at least kind of monitor it. And because I don't know what the statistics are, but have you seen small placentas in reoccurring pregnancies after or subsequent pregnancies afterwards?
So there are 3 reasons for small placentas. And really, there are only 3 reasons. One is there's decreased maternal blood flow from the uterus into the placenta. And in general, when that's the cause, that's not the most common, but I'm starting with the thing that's easiest to understand. That usually actually gets better after subsequent pregnancies. Usually the reason there's decreased blood flow from the mother's uterus into the placenta, and maybe we should just visualize the placenta a little bit so it makes sense to the people listening to this. You can think of a placenta as a bucket, and it's resting on a table, and there are holes in the bottom of the bucket, and there's a water that's coming in one hole and a drain going out another hole. So it's like an aquarium, right?
Mm-hmm.
So mom's blood is the water in the bucket. Then take your hand and dunk it down into the water and wiggle your fingers around. So your arm, your lower arm, and your hand is the placenta, your upper arm is the umbilical cord, and your body is the fetus. And you're sitting on top of the bucket on a piece of cardboard that is over the top of the bucket. So the first reason that the placenta is small, your hand, right, your fingers, can only survive by mom's blood going into the bucket, right? That's where all the nutrients come from. So the placenta belongs to the fetus and the baby, but of course it can't survive and support its, the fetus that's connected to it unless mom perfuses blood into the placental spaces around those fingers. So the most common reason that there's decreased maternal blood flow into the placenta is some immunologic mismatch where the cells that leave the placenta to open up the mother's blood vessels to allow for more blood flow are viewed as foreign by the mother. And she literally attacks them and prevents those cells from getting to her blood vessels. So in general, after a first pregnancy that has this problem, the mother's immune system, and we don't understand how this happens, but the mother's immune system becomes tolerant of this placenta and these invasive cells and doesn't attack the next pregnancy as much. And so just by having another pregnancy, that solves the problem in many cases. So that's one cause of a small placenta. The other is an immunologic rejection. It's sort of an extension of what I said, where the mother's immune system not only attacks the cells that are invading into the uterus, but actually, since her blood is circulating around the fingers, her immune cells in her blood actually recognize these fingers as being foreign and attack the fingers, right? It would be like putting your hand in a bucket of water and having little piranhas eating at your fingertips, right? So that's not a good thing. Yeah. So that immune rejection can be treated, right? We can actually immunosuppress a mother if we see that as the reason for a small placenta. Now, those two together are the least common. The least common of both of those is the immunologic rejection, maybe 10 to 15%. The decreased blood flow might be 30 to 40%. The rest of the cases are an intrinsic genetic abnormality in the placenta itself. And those genetic abnormalities can recur. So I do have quite a few patients who've had a loss because of a small placenta. And then in their subsequent pregnancy, the same genetic issue appears, but the reason their baby survives is that they were being followed more closely now, right? With or without EPV, just being followed more closely is going to, allow any problem to surface to the top. And many of these women are delivered earlier, even without any additional testing. Forget EPV. A lot of these women are delivered at 37, 38 weeks anyway. So, these babies survive, but I've looked at those placentas of women who've seen me for their first loss. Now they have their living baby. And often that next pregnancy has a small placenta. It's just that it didn't run out of gas, right? And so they survive. So to answer your question, yes, these things can repeat, but notice what's important to do. Make a diagnosis of why it happened. That helps in general to confirm that is a small placenta, but also to say to the patient, one, it's not your fault. You don't control the genetics of the placenta or these immunologic reactions. And two, if it has to do with blood flow, we can give women aspirin starting at 12 weeks. We can improve the blood flow to the placenta to some degree. If it's an immunologic rejection, we can immunosuppress them. If it's genetic, we can't do anything about that, but we can at least follow them more closely now. And as I say to all mothers who've had a loss, and this goes across the board no matter what the cause is, a fetal bleed, a cord accident, an abruption, small placentas, if anything changes in their pregnancy, they should not wait to talk to the doctor's office and wait for a nurse to call back or the doctor. They should just go to labor and delivery and say, I don't feel my baby. My baby has changed. I don't know what's wrong, but something is wrong. I need you to check me out. And don't leave until they've completely checked you out, right?
Absolutely.
So that is a basic across the board recommendation. And that alone, if women did that, I'm sure would save babies' lives right there.
Yeah, that's the thing. We're scared to inconvenience anybody or do false alarms or anything like that. So you end up laying down and drinking juice and seeing if the baby moves and all that silly stuff, which ends up not being a good indicator on if there's anything wrong or not. And the problem is there's not a lot of, I would say, medical professionals even educating on the importance of fetal movement. So not many of us are paying that much attention to it, saying, make sure the baby moves 10 times in 5 hours. That's not accurate really, because if it's different than their movements before, then that's when there's probably an indication that something is going on. They're in distress. So that's great advice to just go right to labor and delivery. Because what's the worst thing they can say is like, you're fine. Like, okay, great. Or you're not, but you're already there to have somebody spring into action. I think what people will probably want to ask is, are there any known tests to see if you do have the risk factors for a small placenta before pregnancy?
Not really.
Yeah.
Not really. So the blood flow issue, again, has to do with, and the immunologic rejection, they both are similar. That has to do with the random choice of who your partner is, right? There are proteins called HLA proteins, human leukocyte antigen proteins. These are when you've seen in a high school or something or college where someone says, we need a potential, bone marrow donor for someone with leukemia. Or if you, give blood to a national organization that if you're willing to be an organ, donor for a kidney or something like that, or bone marrow, what they're testing is not blood types, which are A, B, and O. Those are our, simple blood types, but a much more sophisticated typing that there are hundreds of different types, and those are called tissue typing. And the random mixture of who you happen to be a partner with often determines the potential for an immunologic reaction of the mother. Not knowingly, this is not a conscious thing, it's no one's fault, but the father contributes to the pregnancy. So the placenta is half dad, right? And his proteins and his gene expression is on that placenta. So for some couples, right, there's a little bit of a mismatch. So there might be this immunologic rejection. So that's not something we can really change. After the fact, as I said, in terms of blood flow to the placenta, there are studies that clearly show that starting aspirin, not 81 milligrams, but 81 milligrams twice a day at 12 weeks, does definitely improve blood flow from the mother's circulation into the placenta. So that would be sort of my advice. And general advice I would give, anybody who's pregnant, drink enough fluid so that your pee is clear, right? That's how you can tell if you're drinking enough. Forget about, well, I drank this much or that. I don't care how much you drank, right? All I care about is the color of the toilet bowl after
Yeah.
you've peed.
So
You should turn
simple.
around and look at it. If it's yellow, you're not drinking enough. It's just that simple.
Exactly. Well, you've also found other things by just looking at the placenta. The placenta apparently has a lot of secrets. So what other things have you found? Let's say placenta looked normal, baby looked normal. What other things kind of tell you what could have been a cause of death?
Sure. So we're talking about two different things. So there's placentas I get in cases of pregnancy loss. There are placentas I get if there's a pregnancy complication. And some people just want to send the placenta because we've shown that looking at a placenta at birth or after delivery can be used to predict the potential for developmental disabilities, autism, and other things like that. So there are many different reasons for us to look at a placenta. But in terms of the pregnancy losses, in terms of going down the different causes, let's say, first of all, the explanation of the causes depend on the gestational age. In general, and this is in our country, we divide pregnancy losses in two big categories. Miscarriages are pregnancy losses before 20 weeks of pregnancy. Most of those happen in the first trimester. Now, I don't think people realize how many occur. Let me make it clear to people how many. In our country, there are 5 million pregnancies a year. They're not 5 million deliveries a year. They're less than 4 million. So let's just make it even. 5 million pregnancies, 4 million deliveries. That's 1 million pregnancy losses. That's a big number. And most of them are in the first trimester. But really, when you look at the numbers, that means 20%, 1 out of 5, every pregnancy ends in a loss. And it means that at least 25% of all women will have at least one loss if they're completely normal. This is just the rate of losses and successes in our species.
So it hasn't gotten worse or changed. It's been consistently like this.
No. And in fact, not to be callous about it, but this loss rate has to do with, in a sense, the success of our species. These losses, to talk about the miscarriages and focus on them, at least 90% are due to a genetic abnormality. So, again, I'm not making any judgments about trisomy 21 or 13 or 18 or people's choices to have those pregnancies. I'm actually not even talking about those because those are not that common compared to the other losses where the chromosomes are normal. One of the 6 billion DNA codes is abnormal in those cases. And we at Yale, in fact, are just starting to look at families with recurrent pregnancy loss, and we're offering them free a study that allows us to do whole genomic sequencing, which means all 6 billion DNA codes. And we're going to sequence the mother, the father, and the losses. And we're trying to figure out the genetic basis for these pregnancy losses.
Wow.
So again, miscarriages, to summarize, before 20 weeks, about 1 million a year, and 90% or more are due to a genetic issue. And they definitely can recur, right? I have families that have 5, 6, 7 of these losses, but they also have children. So a pregnancy is either a loss or successful. It's usually binary that way. And a lot of people are upset and they say, well, there's something wrong with me. I say, no, there's nothing wrong with you. In fact, ironically, these women are very fertile. They usually get pregnant on the first time they try. And that's one of the characteristics of these women with recurrent pregnancy loss. So that's miscarriage. Stillbirth is a pregnancy loss at 20 weeks or beyond. They're far fewer. there are about 25,000 compared to 1 million. Look at that number drop there, right?
Right.
So after 20 weeks is 25,000. That's the 0.6% or the 6 per thousand I was talking about, right? Compared to the 1/5 of the miscarriages, 20%. And those, the number one cause of stillbirth is a small placenta. That is the number one cause. The number two cause is related to the miscarriages, is genetic. And then going down from that, the next major cause are cord accidents. If the placenta is the root system, then the umbilical cord is the hose that goes from the scuba diver's tank to the mask. If you're underwater, I don't scuba dive, but if you're underwater and that hose kinks, that's not good, right? So kinking of the cord, a knot in the cord, wrapping around the neck, a prolapse of the cord, which means the cord goes into the cervix before the fetus is delivered and comes out, right, into the vagina of the mother, and is like a hose that's tightly kinked. All those things are terrible. The reason we call them cord accidents is they're things in general we can't predict. Now, there's some attempts by using ultrasound and Doppler flow ultrasound to observe the umbilical cord. The issue in my mind, as I said, there will be some people who will say, well, we can definitely do this. If we can't even get people to do EPV, which is a placenta that's not moving around, right? It's static and it takes 30 seconds to do. Just imagine the challenge of getting OBs and MFMs to look at the entire umbilical cord with a fetus that's moving around, right, and is changing position all the time. And even when you see cord problems, like, for example, the umbilical cord is attached to the edge of the placenta, that's called a marginal insertion. It can kink much easier, or even worse, if the umbilical cord attaches to the membranes, not directly to the placenta, it's very unstable. Even when doctors see that and they can see these things, they're not going to deliver you at 26 weeks because you have it, right? And a lot of women, even with these problems, deliver healthy babies. Lots of OBs, if you ever ask them, they see lots of babies delivered with what's called a nuchal cord, the umbilical cord wrapped around the neck. They, in fact, my third daughter had a true knot in her umbilical cord, and she's perfectly fine. She's just lucky, right? I mean, it's just a matter of luck. But a lot of babies are born with these issues. In retrospect, if you have a fetal death because of a knot, then you would have said, oh, I wish that somebody would have seen it. And if they saw it, the question would be, well, what would you do? Would you have delivered this, baby earlier?
Yeah. Well, what would you do?
Well, that's the issue. It depends on gestational age. Would you deliver at 32 weeks? 32 weeks has its own risks, right? To the baby. So look, I'm going to summarize all of obstetrics in 3 words. You ready?
Yep.
In or out. Now that sounds simple, right? But that's actually the art of, medicine and caring for women, because in or out is simple, but there's a balance of risks of in or out every single day of a pregnancy. And so what the art of medicine is, and what you have to do as a physician to take care of patients like this, is to balance the risks of staying in versus the risks of coming out, and what can happen to the fetus, and et cetera, et cetera. So it's a challenging problem. It's not so simple.
No, none of this is very simple. You had said something earlier about a challenge, or if you come across one, that we're your teachers, if you come across one and you're like, I don't know. Have you ever seen one that you're just like, I can't find anything here? Or have you seen something where you're like, I'm not entirely sure what this is, and had to go kind of dig a little deeper? What has that been like?
Well, I'll tell you a current situation that I'm in right now that
Okay.
I'm just starting to wrestle with. So when COVID hit, there were a flurry of papers and people, there were rare maternal deaths during pregnancy, quite rare, but it did happen. There were fetal deaths, stillbirths, because of COVID. And it became clear that, and this is a particular chance event, is that the SARS-CoV-2 virus, right, that causes the disease that we call COVID, binds to a particular receptor protein called the ACE2 receptor. And that ACE2 receptor is in our nasal epithelium, it's in our lungs. So that makes sense in terms of, having this as a pulmonary infection. But it's not clear why, but the placenta is completely covered with the ACE2 receptor. And it's very present in the first trimester. And it actually is highest in the first, about medium in the second, and almost gone in the third trimester. So if you have the virus in you and you're in the first trimester, the virus goes right to the placenta and it gets into those cells. Now, the question is, what does it do? Sometimes, and I have patients, and as I said, in the beginning of COVID, this was the typical scenario. This virus would get into the placenta, and within a week, the pregnancy was lost. It was a really aggressive infection and destroyed the placenta, prevented the placenta from working, and the fetus obviously couldn't survive, and that was the end of the pregnancy. Now there is a new group of patients I'm starting to see, which I'm in the middle of investigating. So I'm just planting the seed. I don't have an answer yet for this, but these are women who are fully vaccinated. By the way, the first group of women were not vaccinated, right? These are the ones that got a very bad infection very quickly, and they were not vaccinated. Now, I just want to send one message out there to everybody. If you're a woman, everybody should become vaccinated. That's number one. You should not be not vaccinated. Number two, if you're considering getting pregnant, you should absolutely be vaccinated beforehand, because having a COVID infection when you're pregnant has a good chance of leading to a stillbirth. But the thing that we're starting to see now is that when women are fully vaccinated, there were people who believed that they could not have infections of the placentas when they're fully vaccinated. And I have seen now 3 or 4 pregnancy losses, stillbirths, of women who had COVID in the first trimester, then it went away, but basically the infection sort of smoldered and was persistent during the whole pregnancy and actually caused a very slow, gradual damage to the placenta to the point that the pregnancy got lost eventually. And so I'm figuring that out right now. First of all, I have to actually confirm that it is due to these, let's call it chronic COVID infections, right? So this is where science comes in. I'm an MD, PhD. I'm a physician scientist, and that's what I do. So I'm going to figure this out. And when I figured it out, if it is truly due to, the SARS-CoV-2 virus, then I think it's important for people to know that even if a woman is vaccinated, it's possible to still have a complication related to COVID infections. So maybe you would say, well, they've been fully vaccinated. That's true. But maybe when you're pregnant, you should decrease the amount of time you spend in public, not go to restaurants, wear masks more often, those kind of things. Because even if you're fully vaccinated, you still may be at risk. And the placenta, as I said, has a particular affinity, or I should say the other way around, the virus has a particular affinity for the placenta.
Isn't that interesting? Wow. I think that, I've been hearing that there are also other things like clots that are becoming more prevalent, and even preeclampsia, and we won't know for decades if this is what's causing it or what's going on here. But I think the moral of the story is just to pay attention to what's going on in your body and push for your doctors to look at it. So, for example, I went in with itchy, red, swollen hands the day that Brody died, and my doctors didn't think anything of it. They thought it was one thing and one thing only, preeclampsia. But if we educate ourselves, which it wasn't, if we educate ourselves and we say, nope, I think that there's something else going on here, and really push, I think that's when we can potentially get some answers and have somebody listen to us, because it's just not always black and white. I don't think there's multiple different symptoms you could have, and some people have living babies and some of us just don't. So it's hard to tell which ones are the red flags. But I think in the matter of a small placenta, I think number one, we do need to pay attention to fetal movement. I think that's probably number one. And we do need to, and this is the thing, like I've said a million times, measure the placenta, get information, tell your doctors to measure. And so many are like, but my doctors refuse. So I guess what I kind of want to And this is the thing, mine are actually refusing. They're not really refusing. They're just like, we just measure the fluid and that's a good indicator of the placenta. And they're giving me the runaround. And how hard should I be pushing is the question. How hard should mothers be pushing their doctors to pay attention to the EPV and the placenta and the things that are going on? So what do you think is the answer to that?
Sure. And let me answer that. But before I leave, I also want to give sort of a little bit of an overview for everybody, some final thoughts.
Of
So
course, I always leave you with the last word. Yeah.
I just want to remember that. So let me address your very good questions. I would say I would divide people into two categories, or maybe three categories. The first category is somebody who's had a pregnancy loss because of a small placenta.
Mm-hmm.
In that case, there's no question in my mind that for peace of mind for them, for just the PTSD impact of having, a pregnancy loss, for all the psychological reasons, if nothing else, doing EPV for them is the humane thing to do, just as a caring human being to another human being. So I think minimally it should be that. But there's a practical reason also. As I told you, these things do recur. You asked the question, the answer is yes, they do recur. So since we know that women with stillbirth have an increased rate of another stillbirth, and they tend to have the same cause for the next stillbirth or loss, it makes sense, since we already know what happened the first time, to be on our, the watch for the same thing happening again. So that's the first category. To me, that is the first category. It's a no-brainer. And I'm personally very disturbed when people won't do that for somebody who was in that position. The second group is somebody who actually comes in with decreased fetal movement. It's their first pregnancy, their fifth pregnancy. It doesn't really matter. They've never had a loss, right? But they're coming in with decreased fetal movement in their fourth pregnancy, let's say. Then just part of the toolbox approach I said before, why not just add it as part of your assessment? Let's be very crystal clear. And remember the raising of your eyebrows that you said before. Here's a fact. You can have a completely normal, if not large, fetus with a very small placenta. Sorry, guys and ladies who are taking care of these women. It is ridiculous for you to not know that. Okay. It is not a one-to-one relationship. Small placenta means small fetus. That is not true. Small placenta can be a very large fetus baby, and that's the worst situation to be in. Okay. So please learn that. That's just a fact. So the second group is somebody who comes in with decreased fetal movement. Just check it out. Do the estimated fetal weight, get that number, do the estimated placental volume, do the percentiles and compare them. In a normal pregnancy, the percentile of the fetus should be the same percentile as the placenta. A normal 50th percentile baby should have a normal 50th percentile placenta. It's a one-to-one ratio. It's not a hard calculation, everybody. Okay. The third group are people who I would just say are very concerned, want to make sure nothing happens. But number one, nothing has happened yet. Number two, there are no indications that anything is going on. Everything is completely normal. There is no decreased fetal movement, and there are no warning signs whatsoever. Would I love for that group to have the peace of mind of having EPV? Sure. But I think we need to take care of the first two groups first and get this into practice. And because it only takes 30 seconds to do EPV, and you're already doing an ultrasound, I hope eventually my fantasy will be that it's just routinely done like every other thing in, an evaluation of a woman prenatally. So I would hold off on the third group. I apologize to those worried well patients, where they're perfectly fine, but they're still worried. We will get to you eventually, but let's triage and take care of the ones that are at much more risk first. I think that's reasonable. I wanted to sort of end with some overall thoughts for your listeners. Number one, there virtually is no time where pregnancy loss has anything to do with you. It's not your fault. There's nothing wrong with your body. You did not cause this. It is not because you rolled over. It's not because of that wine you had at 12 weeks. It's not because of stepping on the brakes too hard in your car. It's not leaning over once to pick up a pencil that dropped to the ground and you think you did it then. I have all these stories of people who literally believe that they know just when it happened and they caused it.
Mhm.
It is not true. You didn't cause it. You can't cause it. It's not possible. That's the first thing. The second thing is, in order to bring closure to a terrible event as a pregnancy loss, a horrible, just, one of the worst things that could happen, I think, to a woman is having a pregnancy loss. We have to find out why it happened. It's completely unacceptable to be told, we don't know, don't worry about it, just try again, all that kind of dismissive stuff. That is unacceptable. It's unacceptable. We need to be able to answer for the family that has a pregnancy loss why they lost their child. And the best way to do it, the best way is by looking at the placenta. There are people who say, well, you should get an autopsy also. Well, yes, if you're willing to do that, that certainly has the potential to answer some questions. But I have to tell you from my personal experience, for two reasons. Number one, we already do fantastic, anatomy scans at 20 weeks. Most of the anatomic reasons for any problems that might happen are diagnosed then. So it's not like it's not like the days of old when we didn't have ultrasound. We actually have a window on the development of that, embryo and fetus early on. So I think for the most part, cardiac, looking at the fetus, structurally, the brain, all those things are looked at in great detail. They do a fantastic job of that. The one thing that really where the answer lies, in my experience, virtually almost all the time, is the placenta. And so therefore, if you've had a loss, please, one, make sure the placenta is sent to a local pathology department. That's absolutely necessary, because if they throw it out, there's no hope. I or no one else can answer what happened. Once it goes to the pathology department, even if they don't know exactly what they're doing, at least the slides are there. They can be looked at by someone like myself. If it's happened right away, ask them to save the placenta. They can even send the placenta to us at Yale. And I hope you make available to your listeners both my website at Yale for pregnancy losses and my email. And I'll say to anybody listening, you can email me anytime, 24/7, harvey.kliman@yale.edu, and I or Kristen will answer you and help you figure out how we can help you understand why you had your loss.
Amazing. Yeah, I'm going to provide all that information. Thank you for leaving on those notes. Really important to release the blame. I think it's excruciating for a lot of these mamas out there. So thank you for taking the time to give all this information. You're about to probably get flooded with some more mamas who want some answers.
Okay,
So
bring it
thank
on.
you in advance.
Bring
it on, he says. Bring it on. Thank you so much. I'm going to send you a follow-up email to let you know what's going on and when it's coming out and all the things that I need from you, because I do all the links to all the good stuff so they can hunt you down and get some more information if they need it. But again, I appreciate you taking the time on a Friday to educate us on all of this and give us some hope, which is important.
Of course. And good luck on your pregnancy. All my best wishes.
You may be hearing from me soon personally. Thank you so much. Yeah, I really do appreciate it. And I'm going to be putting into effect and implementing all the things that I've learned, and I'm going to get to the finish line this time.
Okay, good luck.
Thank you. Enjoy your weekend.
You too. Bye-bye.
Okay, bye. Whew, good stuff. So I hope you guys got something out of that episode. And it's so important that we all talk about this and stay very open about what's going on in the life of loss. So make sure you like, share, and hit subscribe so you get notified when another video drops. And also make sure that you stick around, because coming right up, I'm going to break down the episode and go into detail about what we talked about. So I hope to see you guys over there.